takes part. Okay, I'll start again. Hello, and thank you for joining us to this webinar, which is part of London Global Cancer Week. This webinar is brought to you by the Lancet Gastroenterology and Hepatology, and also the Hepatitis Fund. I'm Rob Briley, Editor-in-Chief of the Lancet Gastroenterology and Hepatology. This webinar looks at opportunities to prevent liver cancer via the acceleration of viral hepatitis elimination. Globally, almost 1 million people are diagnosed with hepatocellular carcinoma every year, which is the 6th most common cancer diagnosis. And almost 750,000 people die from liver cancer every year, which is the 3rd leading cause of cancer death, behind only colorectal and lung cancers. The burden of liver cancer is projected to rise by up to 55% by 2040, so it will place incredible strain on healthcare systems around the world. It's incredibly important that we act to try and prevent liver cancer where we can. Some 55% of cases around the world are caused by hepatitis B virus, and around 20% caused by hepatitis C virus. Both of these viruses are either preventable or treatable. And this webinar looks to explore some of the means by which we can tackle the global burden of liver cancer via elimination of viral hepatitis. I'm now going to hand over to my friend and colleague, Jade Chikoa from the Hepatitis Fund to introduce the first part of this session.
Fantastic. Thank you, Rob. As Rob said, I'm Jade Chikoa from the Hepatitis Fund, where my role is the Senior Advisor for Programs and Partnerships. And I'm delighted to be here with you today to really bring together the experts, communities, and experiences that we have on our panels in both viral hepatitis and in cancer care. Today, we're going to have a discussion in 3 parts. First, looking across the landscape to better understand the situation and opportunities in viral hepatitis and liver cancer, before going into more depth on practical experiences and opportunities to prevent liver cancer through addressing viral hepatitis, before we pause to reflect and discuss next steps for our communities. And before we go into those in-depth discussions, just some quick housekeeping is, firstly, we'd like to let you know that this webinar is being recorded and that recording will be available in a few days for you. We'd also like the session to be as interactive as possible, so we encourage you to share your questions via the Q&A chat box. Please do let us know your name, your organization, and whether your question is addressed to any of the panelists specifically. So with that, we'd like to go into our first discussion, where we'll be sharing more about the situation specifically in viral hepatitis and its relationship, and looking into more depth about the situation in liver cancer. I'm joined by 3 colleagues, Dr. Funmi Lesi from the WHO, Dr. Lewis Roberts from the Mayo Clinic, and Dr. Rachel Halford from the Hepatitis C Trust. So with that, over to you, Funmi.
Right, thank you very much. And I'm just going to try and share my screen. Hello, everybody. My name is Dr. Funmi Lesi, and I lead the Global Hepatitis Program in the Department of HIV, Hepatitis, and STIs at the WHO headquarters in Geneva. And just to note, Dr. Meg Doughty sends her regards. She's unable to join today. And I have a 5-minute presentation, and I'll be brief. But to share that this year, a few months ago, our team at WHO published the Global Hepatitis Report, which presents the EPI of chronic viral hepatitis and the global progress in elimination with data from over 187 countries. Now, the report presents a huge burden of viral hepatitis and a sobering picture of cancer-related mortality. Now, the link between untreated chronic viral hepatitis and liver cancer, as well as decompensated cirrhosis, is quite clear in the scientific community, but perhaps less so in the general population and the general community. So right now, I'll quickly go and highlight some of these findings and its impact on viral hepatitis globally. So this slide shows the estimated over 300 million people with chronic viral hepatitis. 1.3 million died of hepatitis-related disease in 2022. And you would see from the first panel that there's a huge regional diversity of viral hepatitis B, with the greatest burdens in the Western Pacific region, the Southeast Asia region, as well as the Africa region. On the right panel, you see the HCV distribution, and of course, this is more evenly distributed. And just to mention that hepatitis delta has been estimated to occur in about 12 million people. Now, where are we? We all know about the global strategy, or we may not know, but what I've tried to show on the right side is the global strategy, which was developed in 2015, and it provides a roadmap and elimination targets, as well as 5 key interventions for eliminating viral hepatitis as a public health threat. And on the right panel, on top of the screen on the right side, are these 5 interventions, looking at prevention, interventions, and testing and treatment. And you would see that the diagnosis and treatment constitute a key element of intervention, and the data shows very little progress in hepatitis B, with 13% diagnosed, and a lot more progress in hepatitis C, with 36% diagnosed. But compared to the national and global thresholds of 90%, of course, we know that this is way below the thresholds. I also would want to mention that one of the hallmarks of the global strategy is the public health response. And this is a paradigm shift from the usual specialist care of viral hepatitis to a public health approach. And the slide shows the consequences of what must be achieved to reach elimination. Several millions of hepatitis B and C need to be treated. And before I round up, I would say that, so despite the availability of key innovations for testing and effective treatment for hepatitis B, as well as curative therapy for hepatitis C, urgent acceleration is needed to reach the elimination. This is the new hepatitis B guidelines, which we hope will transform the hepatitis B response and provide the direction for real public health due to the simplification of treatment, simplification of diagnosis, and service delivery. It is estimated that these guidelines will really extend the reach of people who require treatment, who are eligible to treatment, 50%, and this is a whole load more than the previous estimates of 15% using the old 2015 guidelines. And just to highlight a little bit more on this slide, the new guidelines recommend treatment of all adults and adolescents over age 12 years old with a possible hepatitis B surface antigen that meet any of the conditions that are on the screen, including fibrosis, including the viremia with a threshold of 2,000, and various other assessments. I also want to highlight that this new guidelines provides diagnosis earlier in the course of the disease and has a dynamic impact on the hepatitis B response. And this is my final slide. And one of the things from the report is these 4 actions, if done at a public health scale, can alter the trajectory and restore the momentum to reach hepatitis elimination by 2030. And these include, in the first instance, testing and treatment scale up to reduce the liver cancer and mortality, reductions in, of course, the incidence, including the hepatitis B burst dose, which I know we'll hear more of, and also the access issues and, of course, the data, always an issue, strengthening surveillance for viral hepatitis elimination. And on that note, I'm going to say a huge thank you and hand over to Jane. Thank you.
Thank you so much, Funmi, and for highlighting what an urgent public health need it is to address viral hepatitis as part of liver cancer prevention, as well as some of those opportunities, strategies, and the new guidelines that we have to accelerate and alter that trajectory. With that, I'd like to turn to you, Dr. Lewis. Can you tell us more about the global situation in liver cancer, please?
Thanks very much. I'll just pull up my slides here. I seem to have lost the screen. Can you see this okay?
Yes, we can.
Okay. Thanks very much. Thanks for the opportunity to present here, and I'll talk about the global situation regarding liver cancer, as Dr. Briley highlighted.
Sorry, Lewis, we've got your whole screen rather than the actual slides. So.
Oh, sorry.
That's all right. Would you like to maximize the PowerPoint? Is
that better?
No, we're still seeing it on top of other.
I'm just going to stop for a second here. Not sure. How's this now?
Perfect. There you go.
Sorry about that.
No problem. Thank you.
Great. So thanks again for the opportunity to present. And what I'll talk about is the global situation for liver cancer. As Dr. Briley mentioned, liver cancer is the fifth or the sixth most common cause of cancer globally. And it's the third most common cause of death from cancer. And in particular, if we look at the major cancers, one of the things we recognize is that liver cancer is the most lethal of the major cancers. So if we look here, what we see is that in terms of mortality ratio, there are approximately 87% of people diagnosed with liver cancer will die within a year of diagnosis. Another way of thinking about this is that there's only a 13% one-year survival from liver cancer globally. So this is a really lethal cancer. In the highest incidence countries, particularly in Africa, there's also a young age of onset, with half of affected persons being diagnosed with liver cancer below the age of 45. So this makes it a particularly high burden because these are people often in the most productive phases of their lives who are being diagnosed with cancer. And as Dr. Leshy mentioned, the liver cancer rates tend to reflect the rates of chronic viral hepatitis worldwide. We can see chronic hepatitis B here in this graph, in this image, and seeing how the major burden is in Asia and sub-Saharan Africa. And if we look back at the liver cancer rates, we can see how they mirror the rates of viral hepatitis. So it's important for us to accelerate action to address viral hepatitis to prevent liver cancer, because it's been shown that reducing the damage to the liver from viral hepatitis can substantially reduce the risk of developing liver cancer, and in many studies by up to 80%. So early diagnosis of the risk factors for liver disease allows prevention of these long-term complications, including liver failure and liver cancer. We know that treating viral hepatitis reduces the risk of liver complications, and particularly in those who have had viral hepatitis, chronic viral hepatitis, and have scarring or cirrhosis of the liver. Surveillance for liver cancer in those individuals results in diagnosis of liver cancer at a much earlier stage of disease when it's much more effectively treated. And of course, treating early stage liver cancer, again, is much more effective and less expensive than treating late stage liver cancer. So it's really important that we have that sequence of trying to reduce viral hepatitis, identifying individuals who are at risk for liver cancer and putting them in surveillance so that we can treat them early and most effectively. And this is an example of some of the data globally from different countries around the world, and showing that, for example, in Japan and Taiwan, where there are national programs, first of all, for vaccination of all infants against hepatitis B to reduce hepatitis B rates, for screening all adults so that hepatitis C can be treated and cured, hepatitis B can be suppressed so that the rates of liver cancer are low. And then there's national surveillance programs for individuals who are identified as having risk of liver cancer. We see these relatively high rates, over 50% 5-year survivals. In Taiwan, actually up to 70% 5-year survival of individuals diagnosed with liver cancer. And this compares at the bottom of our scale here with sub-Saharan Africa, where 95% of individuals are diagnosed with advanced stage liver cancer. And what we find in these in sub-Saharan Africa is a median survival of only about 2.5 months. So clearly, the efforts to reduce viral hepatitis rates have a major impact on viral hepatitis and consequently on liver cancer rates. And so I'll stop there. This is just a picture from Africa Hepatopancreatic Biliary Cancer Consortium, and just to make the point that it's really important that we have global collaborations to work to eliminate viral hepatitis. In Egypt, for example, where this initial conference was held, large-scale population screening and treatment has resulted in the cure of over 4 million persons over about a 5-year period, resulting in substantial reductions in liver cancer rates. In Ghana, in partnership with Egypt, we have launched a micro-elimination campaign called Stop Hep C in Ghana, with the initial goal of curing 50,000 people, and then expanding to treatment of the approximately 500,000 people that are infected with hepatitis C nationally. So these two diseases are strongly linked, and I think work that we can do to recognize the link between chronic viral hepatitis and liver cancer, and to work to eliminate viral hepatitis, will result in elimination and substantial reduction of the burden of liver cancer globally. Thank you.
Thank you so much, Dr. Lewis. And I think it's really clear that link between viral hepatitis and liver cancer, not only as a risk factor, but also as an opportunity. And the data, it speaks for itself to an extent of the need to bring together these different pieces of the puzzle to address liver cancer and this growing burden over time. Rachel, I'd love to turn to you next to hear your perspective on why it's important for us to accelerate actions and what opportunities this has for patient-centered care.
Thank you, and thank you very much for the opportunity to speak today. So my name is Rachel Havard, and I am here today with 2 different hats on. So first of all, I'm CEO of the Hepatitis C Trust, and I'm going to speak from that position now, but I'm also the president of the World Hepatitis Alliance. So in thinking about, when I was asked to speak, how important it is to accelerate action to address viral hepatitis, I thought, rather than present slides, the best way that I can share this message with you is to share with you Neil's story. So we're going to play Neil's story. If you can play that now, please, Rob.
There's now a simple test, there's now a simple cure. If you feel that you may have taken a risk, look up that information and see, and just get a test. It's so simple. So my name's Neil. I used to work for the Hepatitis C Trust, but I've had to give that up due to ill health, as I'm sure we'll go into in a while. and I'm from Doncaster in Yorkshire, and I'm a very proud Yorkshireman. So I believe I contacted Hepatitis C through sharing injecting equipment. I started using drugs intravenously in my early 20s, which was around about 1990. And so I wasn't actually diagnosed until late 2016, which was probably at least 20 years after I'd contacted it. I ended up in hospital with severe stomach pains, and the specialist did a scan of my liver rather than a blood test, and it showed real cirrhosis and swelling. So he did some more blood tests, and that's when I was diagnosed with hepatitis C. At first I was really angry. I wanted somebody else to blame. It couldn't possibly be me. If I'd have had it all these years, I would have known about it. And then I then moved on to how can this have happened? The realisation was that I'd caught this in the 90s in injected drugs, and my thoughts were then is how can this have happened? It's 20 odd years later and I'm only just finding out. And my next thing then after that was to think, I've got to help to stop this happening to somebody else. So once I'd been diagnosed with hepatitis C and got rid of it, I then, because of the damage that was done to my liver over the 20 whatever years that I'd had hepatitis C, I had serious cirrhosis of my liver. There was a chance that it would turn into cancer. Last August, which is August 2023, my scan showed that actually it had turned cancerous, and unfortunately in the 2 months between it spread as well, so it's now terminal. So it's it's affected myself, my family, especially my children. It's affected everybody, because again I thought because I've been cured I'm all right now, but I didn't realise the seriousness of the cirrhosis that had happened because I had not been tested previously. So my message for anyone is, if you've previously taken any risks at all, even if it's only once, just get a test. It's a simple test, it's so simple. And you will know, and the medication, there's no side effects for it. It's just a tablet for either 2 or 3 months, and you'll get rid of it. My cancer is the end result of not being tested over 20 odd years. This disease does kill, and for just a little blood test, just to give you peace of mind, just get a test. Please get a test. Don't end up like me.
So, oh goodness me, sorry. I've actually seen the video, and I know Neil's story. He's worked for us for many years. He worked for us, but it still affects me because no one needs to die, and I think it's providing this is why we're having this meeting today. This is why we need to raise awareness, and this is why we need to have these conversations about increasing testing, increasing awareness, particularly, for early diagnosis. There are many opportunities for improving patient-centered care around this, but, I think right at the top line of this is we have to increase testing, and just want to quickly say before we move on to the next part, that the first World Hepatitis Testing Week begins on the 18th of November, and that is a global drive to dramatically increase testing and diagnosis. It's been created by the World Hepatitis Alliance, and it's supported by national, regional and global stakeholders. I guess there will be many people that see this or are involved in this meeting, that will have known somebody that's affected by hepatitis who's then gone on to have cancer. I think that when we think about testing, everybody has a role to play within this. You know, keep people with lived experience at the centre, because they are really good at reaching populations that sit outside healthcare systems. They address stigma, you know, and this is Neil's message. You know, he was incredible at delivering the message when he was alive, and unbelievably, he's continuing to spread the message now that unfortunately he's not with us. So I'm going to hand it back there, and I'll thank you.
Thank you so much, Rachel, and thank you for sharing Neil's story and messages with us. I think it's really resonated with our audience coming through on the Q&A requests to share the video, which I believe is on the Hepatitis C Trust website, and we can also share it widely with everyone here today. So thank you for that. I'd like to share another question that's come through the chat together with you, which is from Kenneth. Given the insufficient global funding for hepatitis B, which is being clearly highlighted as a risk factor for liver cancer, how can we better advocate for increased investment in prevention, diagnosis, and Rachel, as you said, in testing and treatment at both the global and national levels? You know, are there opportunities for discussions around integration and triple elimination as part of that advocacy strategy with donor organizations, for example, those that work in the HIV space, to start thinking about funding viral hepatitis specifically, and especially in Africa? So there's a few different components to that question there. Funmi, can I come to you first for your thoughts and reflections on sort of those advocacy messages that we could have around prevention, diagnosis, and treatment, and how it could build on the existing work that's happening in integration and triple elimination?
Thank you very much. That's a complex question with multiple parts. So possibly I'll wear a public health perspective. And I think the story of Neil was incredibly moving. And I just want to highlight that this year alone, I've met 2 survivors, 2 liver cancer survivors, whom Rachel knows very well. One from Senegambia. He had hepatitis BD, and he had the access to a liver transplantation. And also somebody in Pakistan, whom we met on World Hepatitis Day. We need more incredible stories like that. We need strengthened awareness, public awareness. So we talk about demand and supply. We need more demand and strengthening of civil society to have a voice that will have an impact. So that's the first thing, awareness, and Kenneth is right on track. And I know that one of the objectives of today is to highlight the connection between cancer and viral hepatitis. Another important thing we need is data, and that is the whole truth. We have global estimates, we have regional estimates, we have national estimates. Countries are moved when they see data from their country. And the data is real. For example, in Egypt, we are supporting what we call is sequela surveillance. And we're looking at their liver cirrhosis and liver cancers. And we note a decline in the rate of decompensated cirrhosis, just with less than a decade of treatment for hepatitis C in Egypt. So the data is a strong advocacy tool. And of course, partnerships, and I think the center of the partnership are the people who live with hepatitis B and C, and then the governments. I mean, it's easy to look at hepatitis response from a specialist perspective, which is great and has always been the case, but to reach elimination, to increase resource funding, and to make an impact, the entire country has to take up a public health approach. So that is what we're trying to promote. And I'm happy to say, Kenneth mentioned triple elimination. There's increasing global momentum, support, and resource mobilization for triple elimination. I'm sure we know that the Global Fund is supporting many countries to strengthen their triple elimination. I know that there's the Hepatitis Fund grant, for which many many organizations applied for. We are looking to see that funding as well. And Kenneth mentioned integration. It's very key in countries using the platforms of HIV that exist, using the platforms of primary healthcare, using the same healthcare personnel, and expanding and decentralization of care. There are important issues to discuss, and I think I'll stop here so that other people can contribute. So thank you very much for taking the first go at this very important question. So thank you, Jade. Over to you again.
And then perhaps Rachel, can I ask you to go next, specifically picking up around the part of the question is really about advocacy strategies that resonate, because Neil's story is so incredibly powerful. Do you see messages and opportunities to bring together both the viral hepatitis and cancer care communities around these messages, and how do you see that?
Absolutely, and it's exactly as Fumi's just said and Kenneth raised, it has to be about integration. I think that, we've all worked in this hepatitis landscape for a really long time, and we've had to fight all along for the recognition and for funding, across the world, for there to be funding, and we know that there's been an imbalance between HIV and hepatitis, and the incredible work the WHO has done and the global health strategies to bring all of this together, so we do actually sit together. So I think it's about how do we continue to keep advocating to bring that together. There is, we've got to have, government and policy makers, they need to put testing for viral hepatitis alongside the resource at the top of local and national health agendas, and they need to bring this in line with HIV. But I think there's something about the liver cancer, there's not enough messaging out there yet, and there is real strength in bringing the two together, because I think, 1.3 million people die a year, and we saw Neil's story, and that's a human aspect, but let's be honest, across countries that costs a lot of money, and just the economy of it and the cost to the public purse. When somebody goes through liver cancer, it's the most horrendous death. For anybody that's ever witnessed or been with somebody, it costs a lot of money, and it's not a quick death. There's lots of costs that come along the way. So actually there's an economic thing that we can be lobbying for here as well. So I think now is the time, and just to go back, but we have to, so at the Alliance, we've got this testing week happening. It's about initiatives like, a global testing week, because that raises awareness, and bringing together hepatitis and liver cancer like this in this session and raising awareness through this. It's really important that the integration happens from the top all the way down across sectors.
Thank you so much, Rachel. And just very quickly, and Dr. Lewis, I'm going to ask you to be brief in the interest of time, I apologize. But you mentioned in your intervention sort of that intersection between liver cancer and viral hepatitis really as an opportunity. What is your perspective on the opportunities that presents for increased investment and advocacy?
Yes, thanks. And I think I just really like to reflect on what's been discussed thus far, which is really that awareness is key. And what we've found is that launching a national campaign, for example, in Ghana, which we have over the past year or so, where we are really focusing the whole country on recognizing that this is a problem. You realize that many people have really no concept of viral hepatitis C, for example, as being a major contributor to liver cancer in the country. And we've been able to use this opportunity with Egypt donating drug to cure individuals of viral hepatitis C to actually raise awareness of both viral hepatitis C and viral hepatitis C broadly across the country. And I think, speaking to Professor Leshy's point about data, one of the things that was really helpful was for us to do a survey across the country of viral hepatitis C and hepatitis B rates and identify the regions of highest prevalence of these diseases, because and it actually helped focus the Ministry of Health. It helped focus, parliamentarians from that region of the country. It helped focus the health system on the need to think about this as a national problem and try to address it in the areas of greatest need.
Thank you so much. I think you're absolutely right that highlighting and reflecting on those real world experiences, there's so much for us to learn, and it's also very rich in the existing data and awareness raising messages. So I think with that, then we'll pass to you, Rob, to learn about other experiences. And I also want to acknowledge that there's some additional questions in the chat, and we're going to have a final Q&A session later on. So please do continue sending through your questions.
Thank you very much, Jade, and thank you very much for our panelists thus far. I think the three interventions have really framed the current situation linking viral hepatitis and liver cancer, and also brought home the reality of living with a chronic condition that can cause cancer. I think we've touched upon some of the means by which we can start tackling that, looking at increasing testing, for instance. I think we can also look at this next session. We'll also look at some of the best practices from public health approaches that can be taken to really sort of start tackling viral hepatitis and then therefore liver cancer further down the pathway. So I'd first like to invite Dr. Simbarashwi Mabaya, who's a senior technical advisor at Gavi, to discuss the role that vaccination can help play in preventing liver cancer, the challenges in accessing vaccinations, particularly in lower middle income countries, and what Gavi is doing to support the scale up of vaccinations where needed. Simba, over to you, please.
Thanks, Rob, and good afternoon to everyone. So on behalf of Gavi, the Vaccine Alliance, I would like just to add my voice to this conversation that's going on here about this matter of important public health significance, this critical intersection between chronic hepatitis B infection and liver cancer. As we've already heard, that chronic hepatitis B virus infection is the main risk factor for development of liver cancer. But we also know that the hepatitis B vaccine is an important tool to prevent this infection and has demonstrated remarkable effectiveness in conferring a long-lasting immunity. Widespread implementation of hepatitis B vaccination has the potential to disrupt transmission and reduce significantly hepatitis B incidence. We have seen from Dr. Lewis's presentation how this has also assisted to reduce the incidence in Taiwan and in Japan. The WHO recommends that children globally be reached with at least 3 doses of hepatitis B vaccine. Most importantly, that the first one should be a monovalent, which should be given within the first 24 hours of life. The risk of developing chronic hepatitis B infection varies inversely with the age at which infection occurs. So those who are infected earlier on in life, in infants, they have a larger risk of developing chronic infection compared to those who are infected later in adolescence or in adulthood. So this the birth dose given within the first 24 hours of life is particularly important to prevent vertical transmission of hepatitis B virus. What we've seen is that globally, adoption of the universal birth dose by national immunization programs has been slower compared to the adoption of the other 3 doses which are given later in infants. And the coverage rates, even for those 3 doses, vary widely between different countries. But almost in all cases, they are higher than the coverage of the birth dose. And countries have told us that there are a few challenges that they are faced with in trying to access this birth dose or implementing policies for the birth dose. This includes that they do not have a good understanding of the epidemiology, the burden of disease, And because of that, the national authorities then do not put in place the relevant policies for the hepatitis B birth dose vaccine introduction. We have also heard that the countries often have insufficient funds for vaccine introduction, and there is limited awareness among the public, particularly among pregnant women, on the importance of being tested for the vaccine, also the importance of having their children vaccinated, so they are unable to demand this very important vaccine. So at Gavi, the Vaccine Alliance, we have been doing our part to contribute to this fight against hepatitis B infection since our inception in 2000. We have reached over 760 million children with hepatitis B vaccines. These are the three vaccines which are given now, I think, as part of the pentavalent and also the hexavalent vaccines. But as of June 2024, we have launched a targeted initiative which is focused on scaling up the access of the hepatitis B birth dose vaccine in those countries that are eligible for Gavi support. As of now, 8 countries have already approached us requesting support. 6 of these have had their requests approved, and the other 2 applications are going to be reviewed in the next few weeks. We anticipate it is our hope that this new initiative will further contribute to the reduction in hepatitis B incidence. However, we also anticipate that there will be some challenges as we try to roll out this program for hepatitis B birth dose vaccination. In the countries that we support, one of the primary obstacles is reaching children who are born out of health facilities, because remember that we need these children to be vaccinated within the first 24 hours of life. And if these children are born outside health facilities, it becomes a little bit more difficult to reach them within these 24 hours after birth or as soon as possible after birth. So we are looking at the best ways of reaching these children, and as Gavi, we are funding implementation research projects to gather evidence on how to effectively reach these children. And we always want to ensure that all the support that we are providing is really evidence-based, but we are also working with countries to see how we can be innovative based on their experience, to ensure that these children are reached as soon as possible after birth. The hepatitis B birth dose vaccine is different from all the other vaccines that we have been supporting, and it is a vaccine that will be required to be delivered just after delivery in delivery wards or in postnatal wards for us to get the maximum effectiveness. And it calls on us to relook at the way we organize our services, and hence collaboration between the immunization programs, but as also those of maternity services, maternal and neonatal and child health services, primary health care, and also those services for viral hepatitis control. There is need for increased financial support to these programs to enable larger scale up and also sustainable interventions. And these resources can be also through investment in Gavi, which could catalyze progress towards the global elimination targets. I would like to emphasize at the end of my intervention the key messages from us towards preventing liver cancer, and knowing that from sustained commitment, innovation, collaboration, we can envision a future where the hepatitis B is confined to history, and the time for that action is now, and the responsibility falls on all of us to ensure a future that is hepatitis B free. Thank you very much, and back to you, Rob.
Thank you ever so much, Simba. That's a fantastic overview of the potential impact of birth dose vaccination, and also Gavi's role in supporting those countries that need support to get access to it. It's fantastic to hear that 8 countries have already taken up the new call for support from Gavi. On that note, we'll now move to a slightly more sort of population level. I'm very pleased to welcome Dr. Maya Tesseratelli from the National Centre for Disease Control and Public Health in Georgia. He's going to talk us a little bit about the experience in Georgia moving towards viral hepatitis elimination, looking at what the country has done to implement screening and treatment for viral hepatitis and its impact, and what lessons might be learnt from that experience. Maya.
Hello, everyone. So I would like to thank you again for inviting me to participate in this event and for the opportunity to share the Georgian experience with you. Before I start to talk specifically about the screening activities in Georgia, I want just to briefly tell you about how we started the program itself, this HepC elimination program. So before 2015, we did not have any reliable information on the prevalence of HCV in the country. And in 2015, based on recommendation from WHO and in close collaboration and technical support from CDC, we conducted a nationwide seroprevalence survey to assess the burden of the disease and risk factors. So based on these survey results, the prevalence of active infection in the country was 5.4. That's in 2015. And Georgia was among the countries with high prevalence of HCV virus. The same year, the country's strategy of HepC elimination was developed, and the Ministry of Health launched the HepC elimination program in the country. And as a first step of this strategy, we started a nationwide hepatitis C screening that was followed with the treatment program initiation the same year. In order to achieve the goal to eliminate hepatitis C in Georgia, the current screening strategy aims to expand the scale of screening and to cover the maximum population of the country with testing, while the emphasis is still given to screening measures among those target populations in which the prevalence of hepatitis is high, compared to the general population, such as injection drug users, MSM sex workers, hemodialysis patients, incarcerated population, and other risk groups. And we continue to provide the HCV screening testing as part of routine medical services in the country at all primary health care facilities. Now, free, rapid, and anti-HCV testing is accessible across multiple locations that is supported by a national electronic registry that tracks screening activities in the country. Currently, there are more than 800 sites providing screening services through the country. So, it's really my pleasure to talk about the main results of this program. So since 2015, as I mentioned, so we started HepC elimination program. We have over 6 million HCV screening tests conducted and test about 2.5 million individuals. And as a result, we get about 170,000 anti-HCV positive cases identified. Since 2015, so as we started the treatment program, so about 90,000 patients have received treatment through this program. And in 2021, we conducted the second nationwide seroprevalence survey to assess the progress of this program, and we received really amazing results. So the prevalence was reduced by 67%. So from 5.4 initially, so to 1.8. But despite those efforts, we are still facing some challenges with follow-up on about 20,000 HCV positive individuals to link them to further medical care and treatment.
Thank you very much, Mara. It shows the importance of that mass case finding and then linking those to care. In the interest of time, we'll now move on to hear from Dr. Kiona Suichiru, who is based at the Ministry of Health in Japan. How has Japan integrated eliminating viral hepatitis as part of liver cancer prevention? And what impact have you seen, and what other lessons might there be that you could share with other countries that are looking to eliminate viral hepatitis and reduce the burden of liver cancer?
Thank you, Dr. Bellick. Good afternoon, everyone. I'm Kiyono from Japan. I work for the Health Minister of Japan. It's a lovely opportunity to share Japan's approach to eliminating viral hepatitis as part of a strategy to prevent liver cancer. And I'll share 3 questions. And one is how Japan integrated hepatitis elimination into HCC prevention. Japan has recognized significant link between viral hepatitis and liver cancer, which has influenced our approach to hepatitis elimination. Legal battles on hepatitis B has also promoted this trend. To integrate these efforts, Japan launched a comprehensive national hepatitis program focusing on awareness, early detection, and affordable treatment. The government established a hepatitis screening program to offer free hepatitis B and C tests for adults, with the focus on those over 40 years who are at higher risk of HCC. To ensure continuity, people diagnosed with hepatitis B or C are enrolled in regular follow-up programs where their liver health is monitored closely for signs of cancer. Japan is also implemented the nationwide infant hepatitis B vaccination program in 2016, which aims to prevent new infection early in life, ultimately reducing long-term cancer risk. Furthermore, Japan focused on making antiviral treatment accessible and affordable through subsidies and health insurance coverage. For those with hepatitis B, direct-acting antiviral therapies are fully covered. And next, what are the main results? The results of Japan's integrated hepatitis and liver cancer prevention strategy have been working well. Since the implementation of screening and treatment programs, we've seen a significant reduction in the number of new hepatitis B and C cases, and liver cancer mortality rates have also been steadily declining. For example, hepatitis C infections have decreased as more people complete successful treatments. People are receiving treatment for hepatitis C since the beginning of 2000, significantly lowering the risk of HCC for these patients. And of course, thanks to the vaccination program, new hepatitis B infection have also dropped, which continue to reduce the long-term cancer burden on the future. The national focus on regular monitoring and early cancer detection, which we have subsidies for it, has helped those who develop liver cancer be diagnosed at earlier, more treatable stages, and it improves survival rates and quality of life. And the lessons we could share with other countries, there are many lessons. And first, prioritize screening and early detection is the main one of the things that we have to share. Offering free or low-cost hepatitis testing and follow-up care is essential. Early diagnosis allows people to access treatment early, preventing the virus from progressing to cancer. Second, make treatment affordable and accessible. Ensuring affordable treatment is essential for achieving hepatitis elimination. Japan's approach to subsidizing antiviral medication and covering hepatitis treatments under national health insurance has been working well. So it enables us to reach a large number of people who might otherwise go untreated. And integrating hepatitis vaccination early and focusing on public awareness, and this stigmatization is also important. And finally, collaboration between healthcare providers and policymakers is crucial. Japan's experience shows that strong collaboration among government agencies and healthcare providers and the patient groups can create a field of response to hepatitis elimination. These approaches ensure comprehensive support for hepatitis patients, from diagnosis to treatment and long-term monitoring. That's all for me. Thank you very much.
Thank you very much, Dr. Kiano. It really brings home the importance of sort of integrating different services, and also, you know, as you mentioned, the integration of policymakers and clinical services to really scale up and find those cases and help to start treating those patients and hopefully change the trajectory of liver cancer. In the interest of time, I'm afraid we're going to have to skip the last few questions that have come in through the system. We'll endeavour to answer those after the meeting closes. But thank you again for all of the panelists on this section of the talk. I'll now move to some closing remarks. I'm very pleased to invite Dr. Sonali Johnson from UICC to give us a few takeaway messages from these discussions, and why it's, including discussion of perhaps why it's important to include liver cancer prevention in national cancer control planning and what we should do next. Sonali.
Well, I just want to thank you so much for inviting UICC to be present at this very important webinar. And I've been taking notes because there are lots of areas for interaction, and I'm going to cover some of those in my remarks. I have been asked by the organizers to focus on national cancer control planning, but just to kind of summarize, but also really concur with what my fellow speakers have said. Liver cancer is one of the fastest growing cancers globally, and it has very high incident rates in parts of Asia, Africa, and Europe. And as other speakers have outlined in their talks, liver cancer has one of the lowest survival rates among the major cancers. Dr. Lewis had mentioned this, but also my colleague Rachel spoke about how painful and distressing liver cancer is for patients, but also for their families. And I want to make that point. I want to reiterate that point, because many patients die without access to palliative care and pain relief measures. So really, it is not only a cancer that can be largely prevented, it can be tested for earlier, but many, many patients die without receiving treatment and in a great deal of pain and discomfort. So I will make that point here. Early detection is challenging, but we know that we can scale up coverage of testing. And I'm so glad that our speakers from Japan and Georgia have mentioned that. Treatment options are limited, but early and efficacious treatment is there. So what we really want to do, as our colleague from Japan said, is to make that treatment affordable and feasible, that people are aware of the prevention and the testing of viral hepatitis, so that we can already look for early signs of cancer. And the other point that I wish to emphasize is that we need to work collaboratively across the cancer and hepatitis communities, but as well as the public health community more broadly. And today's meeting, which has brought together many of these experts, has shown that. One of UICC's key areas for action is ensuring that all countries have a national cancer control plan in place that is costed, implemented, and has ongoing monitoring and evaluation measures. What is an NCCP? An NCCP offers government a strategic tool to improve the prevention and management of cancer and ensure that appropriate treatment and supportive care is available based on a country's specific needs and resources. The development and implementation of NCCPs is critical for a country to translate their cancer-specific objectives into action and to reduce the national burden of cancer. Many NCCPs do highlight liver cancer as one of their main cancers, but not all of them talk about the pathway from prevention through the elimination of viral hepatitis and HPV vaccination programs, risk factors like alcohol and obesity, for other liver cancer-associated risk factors, and early detection and links with the country's hepatitis program. In fact, many NCCPs do not talk about liver cancer in this more integrated way. So what do we do about that? There are lots of opportunities to work collaboratively on an NCCP. In fact, an NCCP is or should be a collaborative process. And one of the elements that UICC does spend a lot of time talking about when we work with countries, with our partners at WHO and the International Cancer Control Partnership, which sees the participation of UN agencies like WHO, the IAEA that has its own cancer missions, plus IARC, who really are responsible for a lot of the research and surveillance on cancer. So they're partners in this, but so are other organizations and national institutes of health. What we talk about there is how do we involve these different stakeholders in a national cancer control plan. It is a plan that has to be embedded in an NCD strategy, but also with links to communicable diseases. We know for other cancers, we've been better at that, linking, for example, the HIV community and cervical cancer communities, because human papillomavirus is, of course, the risk factor, the big risk factor for cervical cancer. So these topics can be addressed through technical guidance developed by hepatitis and cancer communities as a part of an NCCP development. Indeed, often there are working groups set up to develop an NCCP. If a country has already have one in place, they're usually 5 to 10 years. There are different points along the strategy to look at how well it's going. Towards the end of an NCCP, countries often do outreach to professional societies and civil society to start to prepare the next one. But again, if you're not invited to the table, demand to be invited to the table. What we also do see, unfortunately, is that NCCPs are not always current. So quite a few of them are out of date. And we do track NCCP development over time and are going to publish a paper of a review of NCCPs from 158 countries, hopefully by the end of this year. So working, as we heard earlier, another point I wish to say is that there are misconceptions about liver cancer. It is very stigmatized. We've done some work on stigma and cancer, and we found liver and lung are particularly stigmatized because there's this idea that the behaviors that led to those are highly undesirable. The fault is in the patient, as we heard also on the movie, very, very moving story that we heard of the gentleman who died, who passed away. You know, people don't know, but there's also stigma for people who maybe did engage in intravenous drug use or whatever. And so when people have liver cancer, they may find it very difficult to talk about it in their families or communities. This may also affect their uptake of care. There may be abandonment of care. So we really need to look at the stigma around hepatitis and liver cancer and work to dispel that stigma and move towards a situation where people are aware and are able to talk about it, their experience. So just to end, as part of our efforts to eliminate viral hepatitis and reduce the burden of cancer, we have to work together. And I think we've all made that point. In our countries, but also globally, to promote accurate information about liver cancer, its risks and ways it can be prevented, as well as where people can go for information and assistance. And liver cancer prevention aligns with broader public health goals, like reducing alcohol and tobacco use, managing obesity, and promoting vaccination. And all of these efforts benefit overall population health and address multiple cancer types, including liver cancer. So in summary, I greatly appreciate this webinar and how we have shown that eliminating viral hepatitis will help reduce what is a prevalent and difficult to treat cancer, thereby saving lives and demonstrating how different areas of health can come together to work effectively to achieve a shared goal. Thank you.
Thank you very much, Sonali. I think there's some very important lessons there that you pull out, and great opportunities for the communities to work together to really push towards elimination of both viral hepatitis and also prevention of liver cancer. Finally, I'd like to turn to Rachel from Rachel Helford again with a World Hepatitis Alliance hat on this time. Can you share with us your key takeaways and stress your take-home messages on the importance of accelerating action to eliminate viral hepatitis?
Yeah, first of all, I just want to say thank you so much to all the other presenters. It's been really interesting. I've learnt masses. Thank you to Sunil. I guess, I think what's really apparent is we have all the tools. When I listen to Sunil and then Fumi and, Garvey, we have all the tools. When we heard from Japan, it's there. Maybe we should just all look at Japan and copy that model. I mean, it sounds incredible to me. But I guess, in terms of call to action, for want of a better word, I think the hepatitis and cancer communities must come together to raise their collective voice to increase awareness of liver cancer's connection to viral hepatitis and to call for greater action. People living with viral hepatitis, they have to have access to affordable and accessible treatment alongside ongoing monitoring for HCC and other liver diseases. And we heard about the stigma, and please, I want to remind everybody that civil society are key stakeholders within this and have an incredible role to play within this. We are great at addressing stigma, reaching the hardest to engage communities. We saw messages from Kenneth, about going out into communities around hepatitis B. Civil society, please don't forget us, because actually we can do this together. And I think we heard from Japan that civil society were at the center of their plans too. So I guess finally, governments and policymakers must put testing on viral hepatitis along with adequate resources at the top of local and national health agendas, implementing strategies that will save the lives of millions of people. I think that we can beat hepatitis and liver cancer together. And just a reminder that actually testing is the first step. So no one needs to die. And that would be my final message. We have a vaccine for hepatitis B. We have a cure for hepatitis C. No one needs to die from liver cancer.
Rachel, I think it's a very powerful message for us to all reflect on there, and I couldn't have said it better. I think you touched on a lot of the key discussion points that we've heard from other panelists as well, of those opportunities that are there, that the tools that we do have, this is a case of bringing our communities together as well as ensuring there's adequate prioritization, implementation and funding to make those a reality, to ensure that no one dies of liver cancer in the future. I'd like to say thank you so much to all of our panelists today for your fantastic interventions. I've learned a lot, and I think I'm sitting here connecting a lot of dots in my head, and I'm sure that you are as well. I'd also like to say thank you to the London Global Cancer Week for inviting us to host this session, as well as to the Lancet Gastroenterology and Hepatology for co-hosting together with me from the Hepatitis Fund today. We will be making a recording of today's session available in the coming days. We'll circulate this to everyone who's attending today, as well as more widely via our social media channels and our website. We'll also be addressing some of the key questions and sharing additional information that has come through from the chat today, as well as linking you through to some of the key resources that have been mentioned by our panelists. Thank you so much. We have a lot of work to do and a lot of opportunities to come together. So I hope that this is one of many conversations to come, and that we'll see you soon.
Thank you.
Thank you very much.